So I'll start then. Okay. So thank you for joining us for the launch of our brochure as part of Rare Diseases Day. This is a day that is celebrated to, put in place to celebrate all different rare diseases, of which primary immunodeficiency is one. It's thought that there is a incidence of 1 in 20,000 individuals globally that has primary immunodeficiency, and that sort of translates to around about at least I say 2,000 Australians. So Jackie, can you tell us about why this brochure came to be?
We were approached probably a year ago now and asked if we knew of a brochure that was available that was published in Australia or New Zealand to make it more relevant for our market. And there wasn't. So we were asked if that was a possibility, and we went and we found funding, and we were happy to take it up. We had the resources, and as AusPIPS always does, if we've got the resources, we go for it. And so we've been working with a number of different stakeholders, so it hasn't just been patients that have been working on it. We've also worked with the medical scientific advisory panel and also relevant government departments and other areas to ensure that the data was not only accurate, but it was also relevant.
Okay, great. Well, it's our pleasure to be joined by Sylvia Zhang, who is one of our medical advisory panel members and a SCIG nurse at the Royal Melbourne Hospital, and she's going to talk to us a bit about this life-saving therapy that we know called immunoglobulin replacement therapy. Thanks, Sylvia.
Thank you, Emily. Hello, everyone. Let me share my screen. Can we see that okay?
We can.
Yeah, perfect.
All
right. Great. I would like to begin the presentation today by acknowledging the traditional custodians of the land on which we meet today and pay my respects to the adults past and present. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. My name is Sylvia, and my background is in oncology and hematology nursing. I'm currently an immunology nurse consultant working at the Royal Melbourne Hospital, looking after the subcutaneous immunoglobulin program for immunology patients with primary and secondary immunodeficiency and neurology patients with chronic inflammatory demyelinating polyneuropathy. And I'm also involved in supporting patients with hereditary angioedema on other subcutaneous therapies. Thank you, AusPIPS, for inviting me to talk about immunoglobulin therapy, which today also coincides with the Rare Disease Day. I think having a patient-centered brochure in different languages would be beneficial, especially for our patients from culturally and linguistically diverse backgrounds. And this is such a great initiative from AusPIPS, IDFA, IDFNZ, Myasthenia Alliance Australia, and Myeloma Australia to work together and develop these brochures. So immunoglobulin and therapy. Immunoglobulins or antibodies are produced and released by plasma cells, and this forms adaptive immunity against pathogens by binding to antigens. Immunoglobulin is subdivided into different classes based on heavy chains. IgG, which is found 75% of the plasma in bloodstream, it recognizes and detoxifies pathogens. IgA, which is 15%, expresses in mucosal tissues. IgM, 10%, it is the first responder to microbes or antigens. IgE, which is less than 0.01%, it is involved in allergy and also provides protection against parasites. IgD, which is less than 0.5%, it is still somewhat a mysterious class, but there's recent new study that shows that there might be a role in mucosal immunity surveillance. Concentrated immunoglobulin is made from pooled plasma from 1,000 to 100,000 healthy donors, and that is from international or domestic donors. Donated plasma is screened and processed in manufacture, and more than 90% of the proteins in immunoglobulin preparations are IgG. So the indications for immunoglobulin therapy, there are two main ones. The first one is replacement. This is for individuals who cannot produce enough immunoglobulin to maintain a healthy immunity. And the replacement therapy aims to reduce infection risks, the frequency, and the severity. It also provides additional immunoglobulin to replace, and it is relatively lower dosing needed to achieve the therapeutic effects. The second indication is immunomodulation, and that is for individuals with autoimmune conditions such as neurology conditions or some of the dermatological conditions. It is used to modulate the immune system, and it will provide activities of anti-inflammation and immunosuppression. It is required in a higher dose, and to put in perspective, for replacement dosing for immunology patient, it is 0.4 gram per kilo per month. Whereas for someone who has a neurological conditions such as CIDP, they might need to have 0.2 gram per kilo per week. Another indications is hyperimmune IVIG, and this is in high concentration of specific antibodies against antigens. It is used for post-exposure prophylaxis, including cytomegalovirus or COVID. There are two main types of immunoglobulin products. The first one is intravenous immunoglobulin or IVIG. It comes in 5% and 10% of concentration. It usually requires the patient to come into the hospital for a day or multi-day admissions for the administration. It will also require venous access and usually 4 weekly unless the patient requires a very high dose, which they might have to come in more frequently to 2 weeks or 3 weekly or even for 2 days in a row. They usually will have a high peak trough. As you can see in this graph here, in this black line, so when the patient receives IVIG, the trough will go really high up at week 1 after the infusion, and slowly it will goes down by week 3 to week 4, and that is when the time that the patient may feel quite tired, and that is the time also indicates that they will need another infusion. And so at week 4, they have another dose, and the trough goes back up and goes back down in another 3-4 weeks time. With the subcutaneous immunoglobulin, or what we call SCIG, it comes in 16% and 20% concentration. Patient receives training by the nurses, and then they can go home and administer this infusion at home and also be self-managing. No venous access is required, and usually they will need 1 to 2 times per week depending on the dose. They normally will have a more stable trough. So you can see this blue line up here. So when they get started, the trough will slowly rise, and by week 1, week 2, it will start to stable at the therapeutic immunoglobulin level. There's also another new alternative, which is called a hyaluronidase facilitated preparation. So what it does is, before giving the immunoglobulin to the patient via subcutaneous route, the hyaluronidase is injected into the subcutaneous tissue. This helps to break down the extracellular matrix under the skin. And what it does is actually helps to accommodate for a larger volume and easier absorption of the immunoglobulin. And this is very useful for patients require a very large amount of immunoglobulin. And this is one of the alternatives I've come across when I was attending a conference in Europe back in 2019, which is an immunology conference. So the criteria for immunoglobulin therapy. The supply and usage is governed by the National Immunoglobulin Governance Program, along with online systems, BloodStar and BloodNet. The IVIG criteria, eligibility check, and dose calculator is available online with this website. SCIG, at the moment, there are 5 approved access conditions. Primary immunodeficiency disease with antibody deficiency, specific antibody deficiency, acquired hypogammaglobulinemia secondary to hematological malignancy or post-hematopoietic stem cell transplantation, secondary hypogammaglobulinemia unrelated to hematological malignancy or post-hematopoietic stem cell transplantation, or chronic inflammatory demyelinating polyneuropathy, including IgG and IgA paraproteinemic demyelinating neuropathies. So some of the conditions that receive immunoglobulin therapy are the ones below. So this is a sum of them, not every one of them. So for immunology, there are primary and secondary immunodeficiencies, such as the common variable immunodeficiency or CVID, specific antibody deficiency. With the hematology, we have immune thrombocytopenic purpura, hematological malignancies such as lymphoma or leukemia, or chemotherapy or stem cell transplantation related hypogammaglobulinemia. Neurology, chronic inflammatory demyelinating polyneuropathy, and multifocal motor neuropathy. Dermatology, pemphigus vulgaris, and nephrology, solid organ transplantation. So the clinician roles would include the following: the partnership with patients, increase awareness, promote quality of life, provide education and follow-up support, promote cultural awareness, collaborative care with multidisciplinary teams, liaise with external organizations and facilities, and support the governance of immunoglobulin therapy. So patient education is very important for someone who is just started on immunoglobulin replacement or immunomodulation therapy, or also for someone who receives immunoglobulin as an ongoing therapy. So education and assessment. It's important to assess patients' condition and health literacy, the psychosocial and lifestyle change, the tolerance to treatment, provide informed patient decision-making on treatment, and whether it is intravenous or subcutaneous, it is up to the individual's preference as to what works best for them and what works best for their lifestyle. The side effects and adverse events so that the patient knows how to identify and seek medical support. Hypersensitivity, systemic versus localized reactions, headache, flu-like symptoms, localized swelling and pain, IV access extravasation, and scar tissues. So we have follow-up care and management. So follow-up care would be 3, 6, or 12 monthly review depending on the specialty. It will allow clinicians to review the dose and adjust if needed to. We do routine blood tests to check how they're trending with the immunoglobulin levels, monitor for infections or complications, symptom management, provide care and treatment planning, and ongoing education and well-being support. Now, with the borders opening up for interstate and also for overseas, patients on immunoglobulin may also want to go traveling. And if they are eligible, they could consider SCIG. And there are great resources from the Red Cross Lifeblood website for those who are interested in traveling on immunoglobulin therapy. So in summary, Immunoglobulin or antibodies are made by plasma cells as part of our adaptive immunity against pathogens. IVIG and SCIG are given to a variety of conditions as replacement and immunomodulation therapy. The supply and usage of immunoglobulin is governed by National Immunoglobulin Governance Program, as well as with BloodStar and BloodNet. Patient and clinician work together to promote health and quality of life with informed decision-making on treatment options that best suit the patient's condition and lifestyle. It is important to provide individualized patient education and ongoing follow-up support for the continuity of patient-centered care. This is my reference for the presentation, and thank you.
Thank you very much, Sylvia. It's a very informative talk. So I think what we might do is lead in to showing you our website and where you can find the IG brochure that Sylvia has just showed you. So I shall just share my screen. So for anyone who hasn't seen it, can you see my screen? Yep, this is our landing page for AusPIPS. So you can find us at auspips.org.au. And if you go to this website to find the brochure, you just go to patient support and you'll see it there in the drop-down menu, and you can just click there. So as you'll see, there's a nice QR code for the English brochure. And just below this, we have our Auslan translation. So this has a professional voiceover and closed captions. So that is a useful resource for anyone who maybe would prefer not to read it or for other reasons. But what is also key for us to tell you is that we have NATI accredited translations to Chinese, Greek, Hindi, Italian, Samoan and Vietnamese that are coming soon, hopefully in the next week to 10 days. So they'll all be uploaded to this landing page, and there will actually be a QR code for each one so that you can scan that code and get it up on your phone if you want it there as an ongoing resource. Otherwise, you can just click the link like this, and there's the brochure. So Jackie, did you want to just talk us through the brochure?
Yeah, sure. We've started with an explanation of what is immunoglobulin. I mean, not everybody knows, not everybody understands. And we've put this in a really simple language to understand. And also talking about how IG is made and is it safe? Well, often think it's blood products and blood doesn't and has in the past come with quite high risk, but these days it's every donor is screened, and collection and manufacture of IG is strictly controlled and regulated to ensure the product is safe, and includes testing of bloodborne viruses and manufacturing steps to reduce potential risk of pathogen transmission. So these days it's very, very safe, and it's a wonderful product, personally speaking, because I'm on SCIG. Who needs immunoglobulin? Sylvia has just presented through that and explained it. We're talking about who qualifies, who doesn't, and how it works as well. Immunoglobulin therapy can be either intravenous or subcutaneous. So again, Sylvia has presented that and explained that very well. And then we move down talking about intravenous IgG, talking about the side effects, and there's also patient tips. We think that's very helpful because often you can have all the texts and books written by manufacturers or medical staff, but sometimes those tips aren't quite included because as a patient, your perspective is different oftentimes. So then we move down further. We go into about subcutaneous IVIG, so it's SCIG, widely known, and talks about the process you'll go through and the requirements. One very important one is to always, if you're on SCIG, you must comply, or you must do your therapy treatment at home. If you don't do it, you'll get sick, and ultimately, in the end, you'll probably need to go back to IVIG if you can't comply. Then we have patient tips for SCIG, and again, it's very helpful. Then we go on and we talk about how to travel with ski, how to take it home, how to look after it. It is often very sensitive to temperature change, and we do need to be careful and look after it. It's often people refer to it as liquid gold, and it doesn't, not liquid gold for everybody, but those it works, it really makes such a big difference. And so looking after it's important, and being responsible with it. And then we talk about how to travel with ski. Like IVIG, you can travel with it. So there's further information, as you can see. Click on the link and talk to your SCIG nurse or your specialist with about 5 weeks or more notice. And that gives them adequate time to do all the paperwork. So just read this out. This document reviewed by medical professionals and patient to ensure that the patient is correct and relevant. Acknowledge the input of the AusPIPS Medical and Scientific Advisory Panel. We acknowledge the patient organisation below for their review and endorsement of this document. So IDFA, Immunodeficiency Foundation of Australia, IDFNZ, Immunodeficiency Foundation of New Zealand, Myasthenia Alliance Australia, and Myeloma Australia. And ultimately, we're thankful for the CSF doing for sponsoring this brochure, especially because it means so much to patients and helps to educate and fill the gap that was there before we were made aware of it. So we hope that it'll benefit many people and help explain what immunoglobulin is and how it should work and how it does work. Thanks, Emily.
Yeah, thanks, Jackie. So be sure now you know about this brochure to tell people that you know that might find benefit. We're trying to get the reach of this brochure out as far and wide as we personally can, but every extra hand we're getting in spreading this out there into the community is a few more people that are helped and are educated on immunoglobulin replacement. So I think that's a really important thing. So that just leaves me to say thank you for joining us this evening. We've had quite a few people on the call from different members of our stakeholders, so we're really fortunate that they've taken the time to join us this evening. Thank you very much.
And also thanks, Sylvia.
Yes, thank you, Sylvia.
So she's a wonderful SCIG nurse. I can personally vouch for that.
There you go. You want to go for a review on Google now, if that's what the done thing is, isn't it? Google reviewing everyone these days.
That's very true. No, thank you for everyone for attending tonight, and hope you guys can get a few things out of today's talk.
Yeah, thanks, Sylvia. Great presentation, really is.
Thank you.